So I guess we will start. Okay. Good evening, everyone. Respected Dr. Rahul sir, members of the Safe Dental Updates, and dear doctors. So we welcome you back for another episode, which is our 45th episode of Learn from Our Master series, organized by Safe Dental Updates. It's always a pleasure to be here. So for those who are attending our webinar for the first time today, I would like to do a little bit of our introduction. We are Safe Dental Updates, a dental platform in which we believe quality education always ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the observation that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professional and guide your dental journey. So without wasting more time, let us start our series in which our topic of discussion is obturation in radicular spaces, given by Dr. Rahul Singh sir. So I would like to invite Dr. Rahul sir for today's discussion. Sir, please.
Uh, can you hear me?
Yes, sir. It is audible, sir.
Okay. Welcome all. Thank you for sparing your time and giving me, and thank you, Dr. Shanu and Safe Dental Updates, for giving me this opportunity to present a wonderful topic, that is obturation of radicular spaces. Welcome all. So, I am a third year PG resident coming from a prestigious institute of All India Institute of Medical Sciences. We do daily practice in this Center of Dental Education Research, CDR, in AIIMS, New Delhi. This is our department. We do on a daily basis, we do microsurgicals and under microscopes and n number of daily routine endodontics and higher learning also. So my next slide will be the beginning of my topic, that is obturation. As you can see on your screen, the plenty of obturations that we do daily, although I have not put them all, but yes, some of them, so that give you a basic idea of what obturation is and how a tooth, after dealing with problems or after having a carious lesion or having diagnosis of n number of diagnoses such as apical periodontitis, SIPs, irreversible pulpitis, and whatnot. We do root canals for n number of reasons, either intentional or unintentional also. So to do a basic root canal, we should know what are the basic steps and how we are going to do and how we are going to proceed. So obturation is nothing but a reflection of your cleaning and shaping. That is your chemico-mechanical preparation. And it is evaluated based on the length, taper, and also the density and the level of the GP obturation. Both the seals, that is coronal and the apical seal, is important when you do an obturation. Coronal seal means either you do a provisional restoration or a definitive restoration. It should be really effective and should not allow any percolation of any microorganism. And the apical seal is also needful. So here we begin our topic, that is obturation of radicular spaces. But before beginning the topic, why this obturation of radicular space is needed? As I told, first to minimize the coronal leakage, that is from the oral environment, nothing but saliva, and which in turn will lead to reduction in the bacterial contamination. And also sealing the apex from the periapical tissue fluids, not from only the oral environment, but also we have to seal the apical area of the apex of the root, so that the periapical tissue fluids, which already, if contaminated, can lead to persistence of the microorganisms. So sealing both the apex as well as the coronal area. So what can be an outcome of a primary root canal treatment? If a patient come to your clinic with a diagnosis of symptomatic irreversible pulpitis, and you decide to do a single visit or a multi-visit root canal treatment, what outcome are you perceiving? So your outcome will depend on the pre-operative absence of any periapical radiolucency. When you take a periapical radiograph, if the patient is not having any periapical lesion, it increases your success. But if the patient is having a lesion, it decreases. So depends on the preoperative status also. And then once you have done an obturation, the root filling should not have any voids, and it should be extending, although we'll talk about the length of the obturation, but yes, it should be within 2 mm of the from the radiographic apex. And also the coronal restoration should be satisfactory. And all these points are from Nug et al. In the year 2008. So a three-dimensional obturation of the root canal system is essential to a long-term healing outcome. And also in an early radiographic study of success and failure, Engel and colleagues indicated that 58% of the treatment failures were due to incomplete obturation. So your obturation should be apt, it should not be underfilled, and it should not be overfilled. Coming on to obturation, according to glossary of endodontic terms, it is defined as to fill the shaped and debrided canal space with a temporary or a permanent filling material, depending on if you have you gone for a single visit or a multi-visit root canal treatment. And down packing, it's not just a single cone obturation. We down pack, we backfill, we do n number of things. So what is down packing? The compaction of the incremental segments of the heat softened gutta percha to create an apical club. Today we'll learn variety of methods how we can down pack beautifully to achieve that hermetic or an impervious seal. So coming on to the ideal properties, how should an obturation or an obturative material, the properties it should have? So it should be dimensionally stable with no shrinkage once it's inserted into the root canal. Seals the canal laterally and apically, conforming to its complex internal anatomy. That is, nothing but it should have a three-dimensional sealing. The dimension should be in 3 dimensions. That is laterally also, apically also, and coronally also. It should be non-irritating the periapical tissues. What if an already irritated periapical tissues with a lesion and you are excluding your material or either through the help of debris or the irrigation, or your root canal sealer is getting extruded. So you're already irritating on already irritated periapical tissues. It should be impervious to moisture and non-porous and unaffected by the tissue fluid. That is, its solubility should not be really high. Its solubility should be low. And also it should be non-corrosive. Easily remove from the canal if necessary. Always retreatment is also we do on daily basis. So retreatment it also should be kept in mind while you are doing a root canal treatment. Easily manipulated and provides ample working time. That means either your the sealer that you're using should have an ample working time and a good setting time, so that the obturation should be done well in time and also should not be cumbersome. And easily manipulated and provide and sterile and inhibits bacterial growth, obviously, and radiograph and easily discernible on a radiograph, and does not discolor the tooth structure. For this discoloration, when we excise the GP, it should be below for an interior tooth, it should be below the CJ. And if we are doing in a posterior teeth, it should be at least 0.5 to 1 mm below the canal orifices, so that the cervical area of the tooth or the gingiva is not discolored anyhow. So you can encounter variety of patients, such as a patient can bring to you as a necrosis case of a necrotic pulp, or can bring a case of vital pulp, such as reversible or irreversible pulpitis. Although we are not doing RCTs in reversible pulpitis cases, now we are also not doing an irreversible pulpitis. But still, if depending on the patient symptom and your comfortability, if you are even going for a root canal treatment, you should know whether to go for a root canal in a single visit or a multi-visit. If the patient has a vital pulp or a partially vital pulp or partial necrosis, you can say, you can obturate in the same visit. You can access open, you can do your chemical mechanical preparation, cleaning and shaping, and obturate in the same visit. Because there is relative absence of bacterial contamination in that visit, and also because we are expecting if there is multiple visits, so more micro leakage can be seen in subsequent visits. So we are obscuring that. We are not looking for any micro leakage if we are obturating in the same visit. If we are we are diagnosing the tooth as a necrotic pulp, so we can delay our obturation, because in a necrotic pulp, we should again look for the symptoms. If it is an acute symptoms, patient come in really severe pain with cellulitis, with pulp necrosis, or also there is an abscess drainage. So you can delay your obturation. Cleaning and shaping should be done in the same visit itself. give a good calcium hydroxide dressing, so that because of an increased alkalinity of the calcium hydroxide, you can decrease the microorganisms, decrease the number of microorganisms, and also patient symptoms should be elevated as in the patient symptoms should be decreased, and in the next visit, when the canals are dried and the patient is all asymptomatic, you can complete your obturation. Many people are confused ki, what is the length of the obturation, how much should be obturate. So then older concept of obturating till the dentino-cemental junction is there, but dentino-cemental junction is an histological landmark and can't be determined clinically and found to be really irregular within the canal. And also somewhere, if we are looking for like supposedly if we are obturating a distal canal of a mandibular molar, in the dentino-cemental junction on the buccal side of the distal canal can be more apically as compared to on the mesial side. So the position of the dentino-cemental junction varies. And also it's said that the apical point of termination should be approximately 1 mm from the radiographic apexes as determined by the radiograph. So this is the consensus that no matter what, the apical point of termination for an obturation should be 1 mm from the radiographic apex. Also, but this is radiographically. If we talk clinically, your preparation as well as your obturation should terminate at the apical constriction. Apical constriction is the minor diameter, and we should not go into the major diameter, because the average apex as in the major diameter to the constriction, that is the minor apical diameter distance, is 0.2 to 3.8 mm. So combining all these points, we say in journal that if we are doing an 2D, if we are seeing in on a 2D, that is on a radiograph, our obturation should be within 1 mm from the radiographic apex. And also the use of apex locators in conjunction with the radiograph. Supposedly, there are at times in which the opening of the major apical diameter or the foramen is always not at the apex. It can be buccally or lingually as well. So we should not look for key if it is all if your apex locator is showing a reading that is beyond apex and you have obturated at that level, but then you have taken radiograph and you saw that it is 2 mm short. So don't worry, because the apical foramen can open on the buccal as well as on lingual side. So the buccal wall, all the lingual wall will obscure that opening. So it will appear that it is as if that is 2 mm short, but in actual you are on the correct. So always rely on your apex locator and use your radiographs as an adjunct. So core materials plus your root canal sealers, all this combines and form your obturation materials. So we will study this one by one, both the core material as well as your root canal sealer. So historically, core materials have silver cones also. Gatta pacha, that is our present mode and the most common mode of obturation by using gatta pacha. Active GP and resolons also we will study, and variety of sealers also are also used. So we will study this one by one. Coming on to the silver cones. So it is introduced by Jasperi in 1941. Obviously, now you will rarely see a silver cone obturation. I have come across silver cone obturation in retreatment cases, and the obturation was done really 15 to 20 years back. So now we don't do it. It's obsolete. But if you encounter, and why did the people choose to do it was that the rigidity provided by the silver cone made them easy to place and permitted more predictable length control. So there are no chances of extruding it. However, the inability to fill the irregularly shaped root canal system provide leakage, because obviously because of its because they are very tough, and also they can't follow the root canal anatomy easily, and also in long term they release corrosive byproducts which can impede healing. Corrosive byproducts as in silver sulfates and silver chlorides, when they come in contact with the periapical fluids, they release their byproducts, and then they can hamper the healing and also impede the healing, or rather increase that root, the periapical lesion also. So silver cones are obsolete nowadays. Coming on to the gatta parcha. which is the present day and the most commonly used obturating material introduced by Bowman in way back in 1867. We take it from the sap of the trees of Palagrum gutta, and it's nothing but a trans isomer of polyisoprene rubber and exists in two crystal form, that is alpha and beta. What we use, you can see on your image is in the beta phase. That is, the material is a solid mass, and that is we can compact it. But when heated as in 65 degrees Celsius or above, the material changes to alpha phase, which becomes pliable and also tacky and can be made to flow when pressure is applied on that. So, but the major drawback of this alpha phase is that the material shrinks on setting. So now we know that the material shrinks on setting. So you should keep in your mind, the clinical tip here is, whenever you shear off the gatta pacha, always then and there compact it, so that you counteract the shrinkage that is happening. So with the help of plugger, just compact it. The composition is really clear. That is 20% is a gatta pacha, 65% is zinc oxide filler, 10% is the heavy sulfates, which give rhodopacity, and 5% is the waxes and plasticizers. So this is the explanation of the gatta pacha alpha and beta forms, modified by either heat or solvents. They can change by either form. Beta can change into alpha and permits adaptation to irregularities of canal wall. Sterilization is really important, and chemically by 5.25% NaCl for 1 minute. I have made a video on my Instagram channel of sterilization only. What I found and what I know is we don't do because assembly of this gatta pacha. Supposedly we segregated the gatta pacha on our chair table, whatever. The gatta pacha get mixed easily, so we don't we forget in which canal which gatta pacha is to be used. So what you can do is, you can use your older gatta pacha boxes, mark those, there are grooves in their gatta pacha boxes, so mark those grooves as mesobuccal, mesolingual, or whatever canals, and put some already in hypo into that old gatta pacha boxes, and then put your gatta pacha or respective canals and put in those grooves, so that you don't forget which gatta pacha is for which canal. And also on the secondary time, you are also disinfecting the gatta pacha. So this is the clinical tip here, that you can use those old GP boxes and can use for sterilization or disinfection of that gatta pacha. Also, studies are there that you can use 2% glutathione, chlorhexidine and whatnot, but yes, they are not effective because in killing those Bacillus subtilis spores. So the mainstays are in 5% NaCl for 1 to 2 minutes is enough for sterilization of gatta pacha just before your obturation. Coming on to an active GP. Active GP is nothing but a GP that is covered by a layer of GIC. Now, what is the importance of covering this GIC is to form a monoblock. All I know that most of you must have heard about this monoblock concept. So what we do is that gatta pacha cones are impregnated on the external surface with glass ionomer. These GPs come in 4% or 6% taper and also laser verified. So you can use them very nicely. And they are single cones plus an GIC sealer is used with it. So what you do is, if you are using this system active GP, you have to coat your root canal with a GIC sealer and then introduce your active GP. So the advantage of using this system is that it bonds with the root canal and forms a monoblock, so that there is no leakage whatever. But the disadvantage of this system is, if you are planning, if in future if the tooth goes in a retreatment, so retrieving that GP is really really difficult. And also the unset GIC, if the unset GIC get extruded into the periapical area, so it's really cytotoxic. So the two disadvantages are that it is cytotoxic and also it's very difficult to remove. And I have already explained you that this monoblock concept, that is bond between the dental canal wall and the master cone. As you can see in this image also, Ketek endosealer is nothing but a GIC sealer. And these cones can be bent up to 180 degrees without showing any signs of symptom of de-elimination of the coating, and are matched in size to the preparation created by the files. because they are, well, as I already told, they are available in 4% and 6% tapered holes. Coming on to this Resilon, you have already heard about this Resilon and Epiphany sealer. Resilon is nothing but an Epiphany sealer is nothing but a third generation methacrylate based resin sealer. So this forms a secondary monoblock. What I've told you before, that active GP was a tertiary monoblock. Now this is a secondary monoblock. We will study this monoblock in further slide. So the Resilon is resin-based obturation system in which this Epiphany or real seal sealer we can use, and high performance or industrial polyurethane adapted for dental use. It is non-toxic, non-mutagenic, and also very biocompatible. But now Resilon, the use of this Resilon as Epiphany sealer is now obsolete because of the cumbersome process. You have to apply it in various layers. A primer layer is applied because it's self-adhesive system. So a primer layer and then a sealer and then the core is applied. So it's a cumbersome process. So the core is made up of polyester, difunctional methylated resin, biotic glass, and a radiopaque filler. Core is nothing but Resilon core only. And the resin sealer is Epiphany sealer, and which bonds to the Resilon core and attaches to the edge root surface and forms a monoblock. That is a secondary monoblock. This is the procedure. So after drying the canal, a self-etch primer, as I've told, a primer is used to condition the canal. So one step is this application of the primer. Then 2 or 3 drops are placed in the canal with a pipette, syringe, or paper point so that you apply evenly on the canal walls. Excess primer is removed. And then the sealer is applied with the help of paper point, a Resilon point, or a lantular spiral. We'll talk about this, how to effectively apply a sealer on the canal walls. This is also a question. We'll deal with this after this. The sealer takes approximately 25 minutes to set, and it's recommended that the coronal surface of the material might be light cured for 40 seconds. So the master cone radiograph image is exposed to verify the apical position because the NaCl may affect the bond strength of the primer. And also EDTA should be the last irrigant used before rinsing the canal with sterile water, saline, or chlorhexidine. For this EDTA, but in my practice and also in variety of cases I have seen, your last irrigant should be NaCl only. We don't want any other chemical to be there in the canal. The last irrigant, you use copiously your hypo and EDT, 15% EDTA, 5% sodium hypochlorite, depending on the cases. But yes, your last irrigant should be NaCl only. So these are the monoblock that I was talking about. Monoblock is nothing but a single unit. As you can see, it is of 3 types. That is primary monoblock, secondary monoblock, or a tertiary monoblock. Primary is nothing but hydron or MTA. That means we are not putting any layer, any root canal sealer on the walls. We are just injecting the material. Hydron is nothing but a that is primary monoblock, and it's also the first generation methacrylate resin sealer. And MTA, for MTA also, we are not putting any sealer on the walls. So there is a direct contact between the material and the wall. So it is a primary monoblock. And this hydron MTA has a bonding also with the dentine. So it forms a monoblock means ki yes, there is one system. That means the material is somehow bonding with the dentine of the root canal. Secondary, as you already talked about, fiber post also an example, and a Resilon Epiphany system also. Tertiary means fiber post with external silicate coating, or an endorase system, or an active GP that we have talked, forms the tertiary monoblock. Coming on to the root canal sealers, according to the glossary of endodontic terms, it is defined as a radiopaque dental cement used usually in combination with a solid or semi-solid core material to fill voids and seal the root canal during the obturation. Variety of sealers we have used. I have not discussed them in detail. Otherwise, it would be a long seminar. But you should know the indication of every sealer. We in our practice are using, majority we are using this resin-based sealer, or if it's not there, then we are using zinc oxide based sealer. But otherwise, in your practice, there are new sealers like calcium silicate based sealers, nothing but bioceramic sealers. We have seen videos of people posting it. But accordingly, you should decide which sealer to use according to the case, and also it should be cost effective. So as I've told you that how to apply a sealer. So as you know that how you people must be doing it by mixing the sealer on a paper pad, then using the cone, putting the cone, covering the cone with the sealer, and then putting in the canal, or manually agitating it. That is one. But now to effectively coat the sealer on the canal wall, the best way is to use a lentular spiral. If lentular spiral is not there, then the second you use is your ultrasonic activation. Ultrasonic, first with the help of a GP or master pipe or master cone or any 20 or 25K file, just coat the canal wall with the sealer. And then you can use your ultrasonic activation, because ultrasonic activation, because of this acoustic streaming, it pushes the sealer into the irregularities and also the lateral canals. What you see in those, there are, you must have seen cases in this, that there is an apical puffs or there is a lateral canal fill. It is because of the judicious use of your ultrasonic activation, whether in your chemico-mechanical preparation or also in your coating the root canal with the root canal sealer. So the best way is to use a ultrasonic activation, or if at all it's not there, at least manually agitate with your master apical cone. So coming on to the obturation, various obturation techniques that you should know how to do it, and according to the availability of the armamentarium. The most important, not most important, but yes, the technique that we should all know is the cold lateral uh, obturation technique. Now this technique, why this technique is useful is, in our old UG days, all our teachers always said ki at least master this. At that time, we never knew the importance of this technique, but yes, now when we are doing the post graduation, now we know ki how important this technique is, and the majority of cases will require the mastery in this particular technique. So how to do is, once you have finished your chemico-mechanical preparation, you have to select your master cone. Your master cone that is 1 to 2 mm short of the radiographic apex. Now space is created by the spreader and an accessory cone is placed. Now the main point here is that once you have placed your master apical master cone, the spreader that you are using should go at least 2 mm from the apex. It not more than 2 mm, but yes, 2 to 3 mm from the apex. And you should use a biggest possible spreader as you can use. Because if you're using smaller spreader, then you have to put the cone accordingly. And smaller cones means more interaction, more interactive gaps between the GP and more percolation of the fluids and the microorganism. So we should fill the root canal with least possible master cones. So, and only light pressure is required during lateral compaction, because the gutta percha is not condensed, and because a little as 1.5 kg of pressure is capable of fracturing a root. So the drawback of this technique is it provides a non-homogeneous mass, because we are using, there are many, as I've told you, there are gaps also, and there are many GPs we are using. So the mass at the end you get is as a non-homogeneous one. The space between the cones is filled with sealer and also predisposable to the root fracture because of excessive force you put while compacting the GPs. So this is the technique of the cold lateral compaction. Coming on to the warm compaction, can be vertical or lateral. We'll be talking in deep about the warm vertical compaction. It was introduced by Schilder way back in 1967 and filled the radicular spaces in 3 dimensions. Preparing a canal with a continuously tapered funnel and keeping the apical foramen as small as possible, which is the rationale behind your preparation also. We should not enlarge the apical foramen, because there are studies which directly correlates the size of the apical foramen with the failure of the root canal treatment. So the apical foramen should be as small as possible. The mean value for wedging is 0.65 kg, whereas for lateral compaction, obviously it's high. And why this point is important is because in warm vertical compaction also, chances of root fracture is really high. So within the limits of your, we should not press it, we should not use your pluggers with a very brutal force. It should be within the limits that can be done by the tooth, and your obturation should and the obturation should be nice. So on the next slide, I'll tell you how to do this technique. As you can see in figure A, first you have to check the master apical cone fit. In figure B, you have to heat your plugger and then condense it. The plugger should go at least up to 3 to 5 from the radiographic from the anatomical on the radiographic apex. So for your first plugger should be heated one. Then once you have heated the gatta pacha cone, the gatta pacha cone will be removed. You should now you will be left with a 6 to 7 of the GP cone. Now the fin figure C, the plugger that you see is the cold one. That means not the heated one. After usage of every heated plugger, the second plugger that is to be used is the cold plugger. That is at the plugger at the room temperature. So D, in the figure D, as you can see, it is the compacted version of the GP. In figure E, you can see now we are again using the heated plugger, and we are compacting the 3 to 4 sections of the gatta parcha. What you do is, once you have compacted the apical in the apical area, take another GP, cut 3 to 4 from that GP, and then condense it on the previous GP. You have to do is 3 to 4 times till you reach the canal orifice. That is the technique you use in warm vertical compaction. The challenge here is that if we are using that Bunsen, that flame, so chances of hurting the patient is also more. And also you don't have any control in how much heat that you are providing. So there are various other techniques and systems available in which you can, within the limits that can be within the limits of the heat, you can remove the gatta pacha and also condense it, such as touch and heat system or other various systems that are available in the market. So you don't have to heat it along in the Bunsen firmer, in the Bunsen flame, and then remove it. So the advantages of this system is that filling of the root of the canal irregularities and the accessory canals, and also touch and heat unit. That touch and heat that I told you from Cyber or Endo is also an alternative. So the disadvantages of this warm vertical compaction is that potential for extrusion of the material, less length control, because if your apical size of the preparation is high, and if the material while you have put brutal force on the apical GP and if extrude, so there is very less length control, and there are chances of vertical root fracture if you put forces that are not confined within the limits, and difficult in curved canals because the plugger is really straight. So up till a limit only the plugger will go, the middle or that the junction of middle and the apical third. So if the canal is curved, really curved canal more than 40, 50, 60 degrees, so it's very difficult in those areas. And also more tooth structure removed for penetration of digit carrier. If you're trying to do that only, then you have to do filing in that particular area so that your plugger should go and reach at least till 3 to 5 from the apex. So we don't want any excessive removal of the dentine structure, because if you remove excess structure, you're more prone to fractures. So that is a disadvantage of this system. So now our next system is continuous wave compaction technique. Here in this, for this technique to, if you want to do, you should have a system B unit along with you. Now, what is a system B unit? System B unit comes with a system B plugger with a non-standard cone of a similar taper, and also various sizes of system B pluggers. The temperature setting of the machine is 200 degrees Celsius to 300 degrees Celsius. And also there are studies which says that a critical 10 degrees rise within any temperature setting or tip configuration was not observed. As in, if you are using your flame or using a touch and heat, because there is no control over the heat, so you can so what you unintentionally do is you transfer that heat from the root structure to the bone, and the bone get partially necrosed. So the advantage in system B is there is a computerized in this machine. This machine automatically detects when the if you are increasing the temperature too high, so it automatically decreases the temperature within that is most probably satisfied within the tooth. And however, more than 250 degrees Celsius, it's potentially hazardous temperature and can't the tooth can't tolerate that temperature. Coming on to the system B, the procedure what you can do is that compaction is initiated by placing a cold plugger against the gutta percha at the canal orifice, and a firm pressure is applied, the heat activated with the device. What we were doing in previous technique was that we were already heating the plugger and then putting into the canal. What the difference between this technique and the previous technique was, here we first choose the plugger. The plugger should go within the 5 to 7 within 5 to 7 mm in the canal. And once you insert, after putting your master apical cone, then you put your plugger into the canal and then activate the device. So how you cut it at that level is the plugger is moved rapidly, that is 1 to 2 seconds to within 3 mm of the binding point, and the heat is inactivated. And then once you heat, 1 to 2 seconds you heat, and then you press it and then you inactivate, as in then stop your heating and then maintain that position for 5 to 10 seconds. Then again start your heating and then remove it. So the excessive the cone will come along with the plugger. After the gutta percha mass has cooled, a second application of heat is done and the gutta percha is removed. The plugger are designed to heat from the tip to their shank, which decreases the potential for dislodging the compacted mass, which is obvious, and prevents a second application of heat to the material. Then the backfilling on in the previous that is warm vertical compaction, what we were doing is we were putting 3 to 4 mm pellets on the down pack unit. What we can do is system B unit come with a backfill also. We can do backfill with Obturation or any other backfill unit that you have. Once you've down packed it, then you can down pack on that. Then you can backfill on that down pack apical GP. Now there is something known as modified continuous compaction technique also, in which master gutta percha cone with a sealer is there in the canal, and a system B heat source with a medium size tip that is 3 to 5 mm short of the working length. Without trying to remove the hair in the non-modified one, we remove the GP and then we are backfilling it. But here what we are doing is we are just putting a hole as in we are making the, without trying to remove remaining coronal middle portion of the cone, we are creating a space in the coronal and the middle part of the canal. And in that part of the canal, we are putting your heat softened gutta percha. So we are not removing it, but we are condensing, and then the space created by the plugger is filled with the heat softened gutta percha. Now, what the advantage of this technique is a better adaptation of the gutta percha to the canal walls, then the lateral condensation at all cross section with fewer voids and faster obturation time compared to the other technique, and give you a good 3D hermetic seal also. Now, there was a study done in Journal of Endodontics way back in 2007 with the heading of Outcome of Root Canal Obturation by Warm Gutta Percha versus the Cold Lateral Condensation, a meta-analysis. In this meta-analysis, 10 clinical studies were evaluated, and what they concluded was that warm GP obturation demonstrated a higher rate of overextension than cold lateral compaction. So, as I've told you, the disadvantage of that warm vertical compaction is loss of length control. So the length control is really important in warm vertical compaction. And also post-operative pain prevalence and long-term outcome were already similar. So what you need to keep in mind while doing a warm vertical compaction is that you should not overextend your GP while down packing the apical GP. Always have that minimum apical size preparation. Coming on to the thermoplastic injection techniques, in which heating of the gutta percha. Here, what we are doing is we are putting the master cone in the canal and then down packing it. In this thermoplastic injection techniques, we are heating the gutta percha outside the tooth, and with the help of a cannula or a needle, we are putting that thermoplastic or that warm gutta percha directly into the root canal. So, heating the gutta percha outside the tooth and injecting the material into the canal is an additional variation of the thermoplastic technique. That is nothing but thermoplastic injection, in which the best armamentarium, what I can say, is Obtura 3, which we are going to study, which is nothing but an handheld gun. Silver needles are attached to deliver the thermoplastic material into the canal. We have small GP pellets. The pellets are put into the gun, and the gun is switched on. After achieving a temperature more than 150 or 120 degrees Celsius, the GP comes out in a softened form. So what are the basic requirements while you do this type of technique is that apical terminus should be as small as possible to prevent the extrusion of the GP. Canal should be really dry and coated with then we have to coat with a sealer. Then we have to GP to preheated in that gun, and the needle of that gun should be held within 3 to 5 mm within the apical preparation, and gradually and passively injected into the canal. And so when you have injected, now you have to compress it also, because I told you there's the GP contracts. So the problem when you compact is that the GP, it clings to the plugger. So what you can do is just dip your tip of the plugger into alcohol and then compact it. Just dip it slightly. Don't put it all over. And both overextension and underextension are common results. To overcome this drawback, a hybrid technique may be used, in which the clinician begins filling the canal by lateral compaction technique. So, as in, what you do is, first you do a lateral compaction. Lateral compaction is done, and then you sever the GP and into the apical thirds, and then you backfill it with the thermoplastic technique. So first you do a lateral compaction. Lateral compaction gives you a advantage of length control, so that you don't overextend your GP, which is a disadvantage of this thermoplastic technique. So you first do your lateral compaction, and then you can carry on with your thermoplastic technique with the help of Obtura 3. Coming on to Calamus. Calamus is nothing but a similar thermoplastic injection technique, in which a cartridge system with 20 or 23 gauge needles are used. The unit permits, this unit also permits control of temperature, and also the flow rate is also controlled. The 360-degree activation switch allow great tactile sensation during this use. As in, what other technique is, the technique that using thermoplastic injection is, once you press the switch, many machines have that have an inbuilt error of keep on releasing the softened gatta parcha. So Calamus has this only when you press the switch, only that amount of GP will come out, and rest it won't be there. So you have that control in the flow rate. Coming on to ultrafill 3D, this is an important one, in which gatta parcha cannulas are there, heating unit is there, and an injection syringe. So you have 3 cannulas, a heating unit, and an injection syringe. 3 type of cannulas are there: regular set, firm set, and an endo set. These type of cannulas are differed on base of viscosity of the GP. Regular set, firm set are used for medium viscosities, and endo set for least viscosity or higher viscosities. And each cannula has a 22 gauge stainless steel needle that measure 21 mm in length. The needles also are really pliable and can be pre-curved. And also, this is a low heat system up to 70 degrees Celsius only. Coming on to the elements. Elements also a thermoplastics injection technique, in which the element obturation system consists of a system B heating source and a plugger. So this system use a system B wala plugger and a heat source, and the hand piece extruder for delivery thermoplastic gatta parcha. The real seal from the disposable cart. The real seal is the real seal sealer, and the cartridge comes with a 20, 23, and 25 gauge needle for gatta parcha, and 20, 23 gauge for the release of the real seal sealer. Coming on to hot shot. Hot shot is also another variant of this technique only, in which this is the cordless technique. The cordless thermoplastic device that has a heating range of 150 to 230 degrees Celsius. And unit is cordless and can be used with either gatta parcha or Resilon. And the needles are available in similar sizes of 20, 23, and 25 gauges. All these techniques that we are studying have some advantages and disadvantages, but the main aim is to deliver the heated gatta parcha or the softened gatta parcha into the canal and not increasing the temperature of the root canal. Coming on to the Gatta flow consists of a cold flowable matrix that consists of a polydimethylsiloxane matrix filled with finely grounded Gatta parcha. The material is provided in capsules for trituration in an amalgamator. And the technique involves injection of the material into the canal and placing a single master cone to the length. As in which in this technique, you inject the matrix the GP is in the particulate form, as in the 30 micrometer particles is there, and added to the Recosil sealer. Recosil is nothing but a silicon based sealer. So you first, this machine what does is mixes that GP in particulate form with the Recosil sealer, then inject it into the canal, and then after injecting that mixture, we have to put the one single cone to the length, and then the technique is same as that of the warm vertical compaction. The working time is of 15 minutes and cures within 25 to 30 minutes. There was a study in which the purpose of the study was to compare the flow of the Gatta flow and the Gatta parcha into the lateral grooves and depressions. So what this study found that the Gatta parcha flowed significantly better in the groove and depression at 1 mm level when system B plugger was inserted at the 3 mm level as compared to 5 and 4 mm. That means we should insert the plugger as deep as possible so as to get that lateral canal fill and also to get the flow of the GP into the grooves and the depressions of the root canal. One of the technique also of this thermoplastic injection is Gatta Easy that we use in our department, which is the advantage of this technique, that is cordless thermal obturation system. It's very lightweight, reliable apical control with excellent tactile sense also. The needle are also comes in 3 variants and a 360-degree easy rotation of the mouth of the gun, so that we can change the angulation accordingly for the maxillary and mandibular posteriors. And also the heating is really fast. Within 30 to 40 seconds, we achieve a temperature of 200 degrees Celsius. So these were the techniques for thermoplastic injection. Now coming on to the carrier-based GP, in which carrier-based GP, these are the example of examples are thermofill, profile GT obturators, success fill, simply fill, or a JS quick fill. So what the difference is that there are carriers in which the GP is already coated on the carriers, and those carriers are softened and then put it into the canals, and then the excess is sheared off. Let's discuss this in detail. The first is thermofill, in which it is originally manufactured with a metal core and a coating of Gatta parcha. The carrier was heated over the open flame and way back in 1978. Obturators are designed to correspond to the ISO standard file sizes, variable tapered nickel titanium rotary files, or a profile GT or a GT Series X NiTi rotary files. Now, these thermofill has different obturators in which the carrier has a coating of Gatta parcha on already coated, and these already coated Gatta parcha are first softened into the machine, and then these softened Gatta parcha are introduced into the canal and then compacted. Let's discuss this. First, the canal is dried and light coat and the sealer is applied. Carrier is set to the predetermined length and disinfected. Placed onto the heating device, which softens the Gatta parcha, retrieved and inserted into the canal for 10 seconds. Rapid insertion enhances the obturation to fill those depressions and the grooves in the canals. Position verified radiographically, and then after 2 to 4 mm of clean, resection of the carrier is done. But when you resect the carrier, the disadvantages of this system is that if you ever go in future for a retreatment, then retrieval of this system, this core, is really difficult. So let's find the advantages or disadvantages of this technique. The advantages are that ease of placement and pliable properties of the Gatta parcha and potential for movement of Gatta parcha into the lateral and accessory canals. These are the advantages. And the disadvantages are that there is a metallic core. So placement of if we are planning for a post, so preparing a post space is really difficult if we are doing this type of technique. And also Gatta, if we are putting more pressure, then the gutta percha is often stripped off from the carrier, leaving the carrier as the obturation material in the apical area. So the GP remains in the coronal area, and the carrier stripped from the GP and gets into the apical area. So these are the disadvantages. Also, as told you, retreatment is also a disadvantage of this technique. Coming on to thermomechanical compaction, that is nothing but a max pattern compactor. Now we have discussed by heating we can obturate, by using a carrier we can obturate. Now what we can do is we can also soften the GP in the canal by mechanically also we can soften the GP. How we see it? A compactor is selected on the basis of the size of the canal and inserted alongside the gutta percha cone 3 to 4 mm from the prepare length. The handpiece is activated and the friction of the rotating burrs heats the gutta percha. The pliable mass is compacted apically and laterally as the device is withdrawn from the canal. The handpiece the device rotated around 6,000 to 7,000 RPM. And the file that you can see in the picture is an inverted H file or inverted headstrom file only. And the frictional heat produced by the activation of the instrument softens and plasticizes the GP under pressure. So the advantages of this technique is simplicity of the armamentarium and the ability to fill canal irregularities, and it's not at all time consuming. But the disadvantage of this system is that there is a possible extrusion of the material. Instrument fracture is also there if your instrument is older, and gouging of the canal walls can also be there because we are using an inverted H file, and inability to use in canal in curved canals because the instrument is really stiff, and excessive heat generation can also be there. Coming on to the success fill. Success fill is nothing but a carrier-based system associated with ultrafill 3D. Ultrafill 3D that we learned it in thermoplastic injection technique. Now, what we do is that gutta percha is there in the syringe, and the carriers are titanium or radio-opaque plastic. So gutta percha is compacted around the carrier with various pluggers depending on the canal morphology, severing the carrier slightly above the orifice with a burr. So in this technique, what we do is that gutta percha are inserted into the syringe to the measured length of the canal. The gutta percha is expressed on the carrier with the help of the gutta percha expressed on the carrier with the amount and shape determined by the rate of withdrawal from the syringe. And also the sealer is lightly coated onto the canal walls, and the carrier with gutta percha is placed on the canal to the prepared length. That's how we use this successful technique. Coming on to the simplifill. Simplifill is also similar to those carrier-based gutta percha, but the gutta percha in this simplifill technique is only coated in the apical third. So gutta percha or the resolver manufactured for use along with, and the instrument that we use with this technique is the light speed instruments. So the technique is really simple, in which first we check the cone fit. AH plus sealer is required for this technique, and carrier is slowly advanced to the prepared length with firm pressure. And with the plug at the corrected working length, the handle is quickly rotated a minimum of 4 complete turns in a counterwise direction to separate the shaft from the apical gutta percha. So what we do is, after with the pressure, we condense the GP into the apical area of the canal. Now here the carrier is removed. So how we remove it? By literally rotating a minimum 4 turns counterclockwise, and the carrier is removed, and we already get a 4 mm of down pack of the gutta percha. And then the coronal space that is left can be filled with either little compaction or a thermoplastic technique. And the only barrier that you can see, simplifill is a very good technique, but the only barrier is if you have these instruments, first the light speed instrument, and also the ability to retreat in such an obturation system is really difficult. Coming on to the gutta core. Now, as we are using different cores, we have used metal cores, we have used plastic cores. Now the authors have designed cores that are nothing but the core is cross-link gutta percha only. So it is the latest generation of core carriers in which the cross-link gutta percha as the carrier of the outer thermoplastic is the carrier of the outer thermoplastic gutta percha. So there is a cross-link gutta percha, and on that thermoplasticized gutta percha is coated. This makes retreatment simpler as the clinician can simply drill through the carrier to gain access to the canal space. Gutta core was removed in significantly less time when compared with thermophil and thermoplasticide gutta parcha. So the retreatment that we are talking about in the disadvantage of the previous technique is the advantage that retreatment is really easy if we are using this technique. So this is the gutta core only. Lowest incidence of interfacial gaps and voids are really less, and not significantly different from canals obturated with warm vertical compaction. We can also use solvent techniques also uh, to soften the gutta parcha, in which the gutta parcha can be plasticized with solvents such as chloroform, eucalyptol, and also, but using these techniques are abandoned or all obsolete and not used nowadays because the shrinkage caused by the evaporation of the solvent, voids are there, and ability to control the obturation material because we don't know how much the GP will get softened. And also, if the solvent such as chloroform get extruded in the periradical tissues, it will hamper the healing, rather can cause pain cessation, pain in the patient. So these solvent techniques to soften the gutta parcha should not be used. These are some of the cases. Coming on to one of the study in which they conclude that neither technique could completely obturate the root canal. Some of the spaces in the root canal will be left untouched after chemomechanical preparation also and after obturation also. And thermoplastic gutta parcha shows better outcome despite a possible learning bias in favor of cold little condensation. So in our practice, we should, if the canal is curved or according to our armamentarium, first we will always look for a thermoplastic gutta parcha technique. Then only we should jump for either cold little compaction or any other single cone technique. For a curved canal, various studies have been done, and the result of those studies was that most section technique at 2 and 5 mm were either lateral condensation technique or the gutta core technique respectively. And regarding the coronal part, all technique can be used effectively as long as good condensation is achieved. But for the apical condensation of the gutta parcha, we should do lateral condensation or a gutta core technique. Coming on to the C-shape, if we are encountering any mandibular second molar, a C-shaped canal. So at the apical part of the canal, cold lateral compaction and a cold injectable filling technique were more successful compared with the warm gutta parcha filling in the C-shaped canal, in the C1 root canal configuration or a C-shaped canal. Coming on to the internal resorption. Internal resorption is a type of resorption which is encountered within the root canal system itself. So what we can do is in those resorption areas, core techniques left a considerable volume of voids into the resorption. So best is to fill those voids with the help of thermoplasticized GP. That's what they say, that warm gutta parcha compaction technique fill the resorption areas more gutta parcha than the sealer. So thermoplasticide and warm gutta parcha should be used to fill those defects easily, and should be aided with the help of my magnification loops or done under dental operating microscope only. So to conclude, although many new methods are being developed for the obturation of the root canal that are faster and more effective, none of these is without any disadvantage. It is up to the clinician to select each method according to the root canal anatomy presented by the root and the use method that is maximum benefit to the patient without any disadvantage. Thank you.
Thank you so much, sir. So we'll have a little bit of a question answer session, and I would request the audience to post any questions which is relevant to the topic. I request again just to post the questions which is only relevant to the topic. So there's one question regarding about the sterilization of a GP points.
Okay.
So how do you sterilize the GP points, sir?
Sterilization is it's really easy. Once you have selected your master apical cone for any canal, single canal or multiple canals, After taking your master apical cone radiograph, once you've seated the patient on the chair, remove the GP from the mouth and have a designated chamber or a designated plate kind of thing, or I've told that old GP boxes to keep those GP arranged on that, and already filled that box or that plate with 5% sodium hypochlorite. So till the time you prepare the patient again, your GP are already sterilized. Just keep the GP immersed in those 5% hypochlorite for 1 to 2 minutes. That's all.
Okay, sir. So another question is, what's your opinion regarding about single cone technique with bioceramic sealer?
Bioceramic sealer are the mainstay nowadays, and we are using bioceramic sealer daily. But using it with a single cone is fine, depending on, it all depends your preparation size actually. If you can't just obturate your distal or a palatal canal with a single cone there, because those canals are really avoid in nature, and you need either an accessory cones along with it, or you need to condense first that single cone, down pack that single cone into the apical area and then backfill it. So if the canal is constricted, then you can go with a single cone along with the bioceramic sealer. But if the canal is broad, ovoid, or any other canal morphology is there, just do a lateral compaction or do a warm vertical compaction along with backfill.
Okay, sir. So another question regarding open apex cases. How do you obturate an open apex case?
There are this all together a different topic, वैसे, but for an open apex, first to get the working length is really important. Once you are thorough with the working length of your open apex, then you check for the plugger fit. The plugger fit is really important for an open apex. For an open apex, you are looking for if you are planning for an apexification, so you go for a calcium silicate based cements such as MT or biodentine. So first you place your matrix, that is your collagen, and on that collagen should be at the 1 mm from your open apex. Open apex is characterized something more than 0.7 or 0.8 mm. So you have to have a barrier at the end on which you can place your MTA. So first put your collagen or a matrix on the open apex, and then put a 3 to 4 mm barrier of MTA or biodentine. And then after you have put that 3 to 4 mm of barrier of MT or biodentine, then above that you can backfill with GP. But in that backfill also, first coat your canals with the help of a paper point or a GP on the canal walls. First coat the canal wall with GP with sealer, and then backfill the remaining canal. So first a barrier of MT or biodentine, and then backfill with the softened gatta parcha, and then put your provisional or a fixed definite restoration.
Okay, sir. So one more question. Yeah. So there are a few questions regarding about the sterilization of GP. So few doctors had asked, like once they had done a sterilization, it used to change the color. So does that affect the quality of the GP points?
Color, I'll tell you what has happened is the GP will never lose its color. The only color that comes out is at the top of the color. That is, if you're using an F2 or an F3 pro taper GP. So if an F2 is have that red marking on the top of the GP, that comes out. But the GP will never lose its color. That red color or that blue color of the F3 pro taper GP will come out. Rest, the GP will never lose its inherent property from NaCl. And also, it should be immersed for only 1 to 2 minutes, not more than that. Just put your GP into the well or some where you have put your sodium hypochlorite, immerse it for 1 to 2 minutes, take out with the help of a tweezer, and then soak it between the dry and sterilized gauze. Once you have the dry sterilized gauze you have used, you have dried the GP, and then you are good to go for the obturation.
Yeah, so there are plenty of questions which are actually out of topic. So obviously we'll try to answer these questions in another webinars. I think we had done few webinars regarding about the questions which are asked. And you can definitely visit our YouTube channel to see those topics. So I guess we will wind up this question. And if any other questions are there, we will try to rectify in any social media platform. Obviously, our sir has our Instagram page where you can see all the active cases uh, present in his Instagram page. So thank you so much, sir, for sharing your knowledge and expertise when it comes towards obturating the radicular spaces. So many of us would leave this discussion with amazing takeaway points and implement technique as per discussed. And thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive and confident manner. So once again, thank you so much, sir, for this wonderful presentation. We really appreciate your valuable time given for us for this series episode. And I would request the audience to please do check out our sir's Instagram page where you can appreciate his clinical works and do follow him. And to know more about our upcoming webinars and workshops, please do check out our Facebook and Instagram pages. And also, if anybody has missed any previous webinars, you can do visit our YouTube channel. So I would request to please subscribe as well. So thank you all and have a great night.
Thank you.